occluded. So there are many reasons why we can't use our usual access, for example, when there were previous central lines or due to several catheterizations in patients with interrupted inferior caval vein, obstructed superior caval vein, obviously in our patients with bidirectional Glenn and Hemi-Fontan, sometimes if we have to do interventions, we need other access to have a straighter pathway. There might be infection at the site of access. And very important, often the vessel size is a limiting factor. Usually it's the patient size or patient age that is a limiting factor, but often you have a big device or a big introducer and a small patient, and you have to look for solutions. So what are the alternatives? I'm not going to cover all of these, but I think two interesting alternative accesses are obviously transhepatic and transthoracic. I'm not suggesting that these are regular accesses, but I'm going to show you some examples. And then, of course, a hybrid technique, which I'm going to discuss in premature patients. So we are lucky in our unit that our interventional radiologist is quite experienced, and when we obviously we don't need transhepatic access every week, so when we know that we're going to do a patient where we need transhepatic access, the access is obtained by our interventional radiologist. In many other units, the interventional pediatric cardiologist can do this themselves. So I think the important thing is that the person who does it should know how to do it, should know the anatomy and avoid complications, but because actually it's a very straightforward technique and can even be done in small babies. And therefore I think an experienced operator should do it in these cases. So I'm not going to explain all the detail, but obviously if a patient is on anticoagulation, it has to be stopped. Hepatic ultrasound is done to delineate the vessels. These patients in our units in any way are always done under general anesthesia, not under conscious sedation. You need the right puncture material and you need some material to close your transhepatic access afterwards. I think no, I didn't miss a slide. So the technique, according to our interventional radiologist, it differs a little bit in an infant and in child. In an infant, you go more subcostally and aim towards the hilus. In a child and in the adult, you go more in the axillary area, intercostal, and aim towards the peripheral vein. The technique is under echo guidance. I'll show you some photos just now. Gentle aspiration. Check if you're in your right atrium, put in your coronary wire or your floppy wire, and then obviously exchange for first a small dilator or whatever dilator and sheath you will need for your intervention. It is important, especially in small children, that you must remember your sheath might be short and you should not lose your position if you manipulate your sheath to advance the catheter. So it's often a good idea to have two wires to just secure your position of your sheath. This is an example of the echo delineating obviously the veins that has to be punctured. First, the markers or the place where the puncture is going to be done is marked in a non-sterile setting. And then under sterile conditions, doing the echo mostly himself, a puncture is done using the needle I showed you, and usually a floppy coronary wire is passed through the needle. And obviously, before you insert your sheath, you will check that you're in the right position, and then you can start with your intervention. So this is an example of a patient where an ASD was closed via transhepatic route, straightforward pathway. And obviously, if you look at the size of the sheath, you can imagine if you take the sheath out without closing the entrance site, you will have some problems. So I'll come back to that just now. In this patient, it was in the setting of a univentricular heart where the ASD has become restrictive, and due to femoral venous occlusion bilateral and post-Glenn shunting, a transhepatic route had to be taken because intra-atrial stenting was necessary. So here you can I don't know if it's too dark, you can see the stent in position. Again, here one must be careful not to lose your sheath position. Obviously here you've got your long sheath, and we opened up a stent with sequential stent opening. And in the end, the position and your sheath still in the hepatic vein. Now, which type of occlusion technique should one use? I think, well, in all the patients we do occlusion techniques, whether it's high risk or not. The technique is, there's a few possibilities. You can either use hemostatic gelatin sponge, which is soaked in contrast, so-called spongistan, and it's introduced via your sheath into the tract in the liver, controlling with a hand injection through your sheath to see what the position is. You can also use a coil, or you can use some other plug or vascular occluder. Important is to do with hand injections, control as you take out your sheath and see that you sit in the hepatic tract. Usually the day afterwards, control echocardiography or control abdominal echo is done to make sure that there are no effusions or no bleeds. And in these patients, they usually stay an extra day in hospital, not the usual 2 days as in other catheterizations. In this patient, you can see the closure material, the spongostan that sits in nicely and snugly in the liver. So the next alternative access I want to discuss is transthoracic access for cardiac catheterization. And again, I'm not at all suggesting that we are going to do this every day, but it's, I think, important to know the possible alternatives. So for which patients would you use this? Again, specifically in case of difficult atrial access, where you've got no transvenous or atrial access, when you've got no retrograde access, and often it is in your post-Fontan patients, your extracardiac Fontan patients, where you want to treat, for example, pulmonary vein stenosis, and if you have to treat these patients due to arrhythmia. It's important that one knows landmarks when one does these type of interventions, and obviously, again, knowing what the important structures are in the region of where you are going to puncture. In this slide, you can see on the left side, this is a patient post-Fontan where stent in the pulmonary vein was intended, and you can see nicely on the right side which is the intended puncture site for the transthoracic puncturing. This is the sheath after placement, and I don't have a... There you can see, I don't know if you can see it, your sheath basically in place for your intervention to be done. What are the complications in the patients? It can be hemothorax, they can be damage to the internal mammary artery, and one should define your course angiographically, and also it's important to occlude your tract if you take out your sheath. Obviously pneumothorax, and remember the coronaries should be kept in mind when puncturing. Again, I don't think we will do this quite often. Now, the two last interesting cases I want to discuss, or type of pathology I want to discuss where one would need alternative access, is specifically in low birth weight or premature infants. Sometimes it is beneficial in very low birth weight infants with deficient pulmonary arterial flow, and especially in severely hypoplastic arteries, either in tetralogy of fallow or pulmonary, or almost near pulmonary atresia, but where there is a connection between your outflow tract or certainly not an infundibular atresia. It might be beneficial in these patients to do right ventricular outflow tract stenting, because often these pulmonary arteries are too small and the risk for a classical shunt is too high. And in these type of patients, one could consider an hybrid procedure and do direct right ventricle puncture with a beating heart and do your stent implantation this way. We have done it in a few patients, and it's extremely interesting how hemodynamically stable they are, and how smoothly such a procedure will go. So how do we do this? Obviously, it is done in the hybrid operating theatre. what we asked the surgeon to do is identify the pulmonary valve annulus and put a clip there. I'll explain to you why just now. You identify your puncture site, and it's important that you puncture low enough, because we have seen in some patients, if you puncture too high after stent implantation, you might develop after a few weeks an infundibulous stenosis. So you want to puncture below your infundibulum, direct your needle towards your outflow tract, and obviously place your wire. So the surgeon puts a purse string on the right, in the right ventricle on the puncture site. And then again, direct vision. Often we need we use a second needle on the outside as reference to see in which direction we should puncture. A coronary wire is placed. The sheath through which you are going to place your stent is placed. And what is the importance of the pulmonary valve annulus clip is that it is a good reference to see the position of your stent. This is a patient where you can see on the clip placed on the pulmonary valve annulus as reference. You can see the purse string that is made at the entry point. And puncture with the needle, a second needle on the outside as reference to see which direction you should puncture, and then your coronary wire that is placed, and obviously under fluoroscopy you check the position of the wire. The sheath is placed, aspiration, and here you can see the stent over the balloon, and here we can use again, obviously we also do contrast injections via the sheath, but we can use the clip as reference for positioning our stent. Again, these are often type of bailout procedures where the alternatives have a higher risk, and we have seen in these patients adequate growth of pulmonary arteries with the possibility of either enlarging these stents or having a complete correction after a few months if they have a better weight or better general condition. The last patient that I want to present is a severely premature baby, birth weight almost 700 grams, that was part of a twin. And after a week or two, when the normal routine echo was done to check for an open duct, it was seen that the ventricle, the left ventricle was small, that the aorta was small, a small isthmus, and that there was a critical coarctation, although there was a big arterial duct. So at that stage, the patient didn't clinically have a coarctation. The pulses were actually very good, but suffered the symptoms of high pulmonary flow and had management problems, ventilation problems. Prostaglandin infusion was started initially, but after stopping the prostaglandin infusion, the duct stayed open very large, and we had actually pulmonary overflow. The baby was very unstable. There was lung bleeding and systemic hypoperfusion and left ventricle dysfunction. So the problem was, you know, we're sitting with a 1 kilogram baby in a very bad hemodynamic condition, and what are the options? So the options that we thought of was obviously surgery, but in a baby of this birth weight, unstable, we thought that the risk for cortectomy with ligation of the arterial duct would be too high, and that the risk for a re-intervention for recoarctation would be high as well. The other option was obviously to do a normal transfemoral arterial catheterization, placing a stent as bailout procedure. But the case just before this case, a baby of 1.3 kilograms, in which we did a bailout stenting from the femoral artery, died after avulsion of the femoral artery when the sheath was taken out. So with this history in mind, we were a little bit reluctant to take this patient to the cath lab. The other possibility was obviously going via carotid cut down, but that would still not solve the problem of the big duct, and the patient was very unstable. So we discussed with a neonatologist, and eventually the decision was made to do a hybrid procedure, and via stenotomy, a purse string was placed on the aortic ascendens. There was a puncture done, the wire placed in the descending aorta, obviously control angio is done, the stent was positioned, and determining the stent size was done before the intervention. We already decided on echo what size and length stent we would need. So here you can see on the left side, your slightly hypoplastic arch, cartation, and a very, very large duct. So what was done, the stent was implanted, opened up with nice flow, and a surgical ligation, closure of the duct was done, the sternum was closed, and the patient did very well. Obviously, this was not the treatment, the final treatment. After a few weeks, the stent had to be redilated, but this time in the cath lab, and a coarctectomy could be done a few months later. Usually, if we do these bailout stenting, we don't wait too long, because we know that if the stent, our surgeon says that if the weight is okay, it's better to take out the stent around about 3 to 4 months, because it's easier to take out and the surgery is quite straightforward. So to conclude, I think sometimes we have to think out of the box. Again, I don't think we will do hundreds of cases like these every year, but it is important that we keep in mind and that we think of the other possibilities. And it is interesting, again, in these hybrid procedures, how stable these small brittle infants are. And we are very satisfied with the results in these patients. Thank you.